Hello, people. How are you doing? Welcome to episode 149 of the Sports Therapy Association podcast. My name is Matt Phillips, creator of RunChatLive.com. And as always, this episode is being recorded live on the Sports Therapy Association YouTube channel at 8 o'clock. And it's on Tuesdays normally, as it is at the moment. But just to warn you that the episodes next week, for example, is going to be on a Wednesday. Okay, so I've been asked just to remind some people now, if you are going to come and join us live the next Wednesday when we're with special guest Benoy Mathew of Function2Fitness, he's going to be talking about treatment for groin injuries. That's next Wednesday. Okay, so there's the reminder. I got 3 emails saying, Matt, please remind us because we need to know these things. So thank you for reminding me to remind you. There you go. And then the week after that, we're back to the Tuesday on May the 30th, where my guest will be Jenny Bowell of Bowell Education, who will be focusing on diastasis recti, abdominal separation, like we talked last week with Dr. Sarah Rollins. Talking of Dr. Sarah Rollins, amazing episode. We've had Dr. Sarah Rollins on the show before, ex-Army GP and now consultant in sport exercise and musculoskeletal medicine for the Ministry of Defence. And again, I was worried that I was bigging it up too much because the last time she was on the show, she gave this fantastic abdominal breakdown of the hip or buttock. It was buttocks pain. And this time it was just equally as brilliant. If you're into anatomy, you want to hear somebody just telling you all about the anatomy of the anterior abdominal wall, then yeah, check out the episode last week with Dr. Sarah Rollins. You can listen to it obviously on all popular podcast apps, or I would recommend you probably pop along to YouTube and watch the visual, because Sarah's very much with the hands, and a few times she's talking about describing stuff and directions of obliques and things. So it's probably one to watch on YouTube if you like understanding the anatomy. So tonight, in part 2 of this month's focus on the abdomen and groin, I'm absolutely delighted to bring you Dr. Dora Papadopoulou, who's again a GMC specialist, registered trauma and orthopedics consultant for sports exercise and MSK in what I've been informed used to be called Headley Court, but now I'm glad I've been updated. I'm educating myself. It's now Stamford Hall. Absolutely. I mean, all my guests are incredible. I love it when I get to meet and bring you somebody who I haven't been aware of in the past due to my own sheltered kind of life in a bubble. So really excited to bring Dr. Dora Papadopoulou up on the show. Going to be focusing very much on sports related groin issues. And as always, people in the live lounge have been coming through. If you would like to ask questions directly to the guest, then you can type it in the comments. And when you do type in the comments, I can bring your message up on the screen. For example, like now, Penny from Soma Sports Massage Therapy is in the house and says, hola. We've got a Spanish thing. Hola, Penny. ¿Cómo estás? Penny's in the house. Glenn Murphy has come through. Glenn is saying, hi, Glenn, how are you? Matt, we will have to stop meeting like this. People will talk. Thanks, Glenn. That's great. You're always second or third through the door. It's wonderful. And other people are coming in the live lounge. If you are in the live lounge and you want to ask questions, then do please just fire away. I've told Dora that she's welcome to interrupt me and herself if she sees a great question in the live lounge. So do just take this opportunity. Such a great opportunity to talk to one of the leading consultants with everything to do with hip and groin. So I think that is all of the information you need out of the way. So I think now it's time to bring up other people coming through the lounge. Wonderful. Hey, Becky. I was wondering where you were, Becky. Great to see you. So now I shall bring up, without further ado, Dr. Dora Papadopoulou. Dr. Dora Papadopoulou. I'm so impressed with myself. I'm getting your name well, aren't I? I've said it 6 times and not one mistake. Is that right?
I'm more impressed than you are, Matt. Thank you so very much. First of all, good afternoon, good morning. I don't know where people are listening from the world. Thank you for the kind invitation. It's a great pleasure to be here with you today. I ask people to just ask questions, but if you feel that you don't want to send the questions in the chat, feel free to email me, find me on Twitter. I'm quite active over there, and just ask questions. What I always say, just use me. Use this 25 years of experience, and I'm here to support. I love supporting young people, and so I'm here to do this.
That's fantastic. People listening to the podcast, the energy in the room at the moment, you've got so much energy. It's fantastic. It's infectious. But yes, on Twitter, very active. Definitely worth following at Dora, which is DORA_sport_med. I don't know how you find time to share things on Twitter as well as, I mean, when I first contacted you, you were between flights or something. I can tell there was an urgency, like I'm about to board, I have to. And I was like, oh, I'm never going to hear from her again. But you were there, like as soon as you landed, you were messaging me. So where were you? You've just come back from a big meeting abroad, haven't you?
Yeah, I had a big meeting, and I mean, it's my life is about meetings all the nights, the meeting and groin meetings, hip and groin meetings, and all that. We'll talk about this. So let us start to share with people what I learned over the years. So today we'll talk about groin-related injuries, and when I talk to people and colleagues and say, "Come and work with us," the answer is no, no, no. You know. Groin is very complex. It's very difficult. I don't want to work groin. And it's not. But to be honest, yes, it is a complex pathology. Why people, they are frightening? It is an extremely complex anatomy. Let us say this. There are many mixed and coexisting pathological conditions, and this is happening all the time with groin. Something really difficult again is that the clinical and diagnostic findings in groin are not always in harmony, and this is another problem. You know, when you have a fracture, you X-ray the person or an MRI, you will see the fracture. With groin injuries is not the case. And something very important, we talk about the pelvis here, and we have whole large force producing muscles there. We have many muscular force dispersal across the pelvic bone, and it's a lot of interactions. Many muscles, many tendons with deep insertions interacting, and these forces play important role. And some people, they maybe had an injury to their abdomen, and then we will see the pain in the adductor and the other way around. And I forgot to say that, today's lecture the timing was great because Sarah Rollins talked about the abdominal wall, it was a great lecture, as you said. And then today I will talk about the classification, what we should know about the groin. We'll talk about anatomy. I'm not going to talk about treatment because then Benoy Mathew will talk about treatment next week. So it's a very good flow. But if you have questions about treatment, ask me. Maybe we can talk about a little bit about surgical treatments. So yes, it is a complex, and if all what I told you is not enough, we have a complex nerve supply that's causing referral pain there. And this is another issue we have to think about always. We have many nerves playing an important role, like ilioinguinal nerve, pudendal nerve, hypogastric. And this is the reason that lately we work also when we treat, or for diagnostic reasons, we start to do blocks in this area as well, and they work very well. So if it wasn't complex enough, we have a complex nerve supply. So we're going to talk about anatomy, a bit of diagnosis in acute and long-standing groin pain, a bit of epidemiology, and then in general, the principles. I will talk to you about something very important, and this very important thing is the Doha Agreement in terminology. And the reason I'm going to talk about this, because it's a very important step on how to simplify what we thought that is complex. The Doha Agreement purpose was to highlight those entities we're going to talk later involving groin pain, in order to have focused treatment and be able to compare the results in clinical studies instead of calling everything groin pain, or instead of using fancy terms causing confusion in communication between us when you refer patients to me and the other way around. the communication with patients. So let us start with a bit of anatomy. I always say that if you have to learn one thing in the groin, please know well your adductors and know well your adductor longus. Why? The adductor longus is play important role. Easy to palpate, very superficial tendon, which comes up, crossover, gives superficial fibers over to the abdominal wall, and this is the connection. And in the abdominal wall, we have the external ring where we can check for hernias and all that. So an important thing is, talking about these forces, is to remember that these muscles are not sitting in front of the pubic bone like loosely. The superficial fibers do pass over, goes up, and also not to forget that in front of the pubic bone we have the pyramidalis tendon. So remember that these muscles, they have strong connections, large insertions in the pubic bone, and this is and they produce the force. The force producing muscles. So in front of the pubic bone, we have the rectus abdominis, we have the pyramidalis, a concept that a very important muscle tendon we are going to talk about. Not a lot of people know about this, but plays important role, and then the adductor longus. So remember from this that we have these strong connections between the pyramidalis, the adductor longus via the anterior pubic ligament. Here I would like to tell you about the plaque complex. I don't know how many of you have heard about the plaque complex, but thanks to Professor Childers, the last maybe 10 years, we know about this anatomical concept with the pyramidalis anterior pubic ligament adductor longus complex and the role that plays in the adductor injuries. So 10 years ago, it would be very difficult to diagnose such an injury. The last few years, I see them more and more and more. So this is probably something new for the listeners today. So what we have to remember of this anatomy roundup: many superficial interconnections, large muscles, rectus abdominis, adductor longus, and large insertions that play role in these searing and dispersal forces between the groin and the abdomen. And do not ignore the pyramidalis and plaque complex. And if you have questions about this, ask me, and I will send you all the links, because you can read as much as you want. Another very important structure, and I know that people talk a lot about iliopsoas. We receive so many referrals about iliopsoas issues, but it's overlooked a bit. Is the iliopsoas, which comprise from iliacus and the psoas-major. So the psoas-major distally has a tendinous insertion with a very small fatty cleft in between. And then the iliacus muscle, which is very important muscle, but people, they don't talk about it, has a muscular insertion with a small intramuscular tendon. Now, when we have an injury to the iliopsoas, quite often we have injury proximal and distally to the iliacus as well. So think about this every time you have an iliopsoas injury. Another very important structure, and probably it's more important when we talk about acute groin injuries, is the rectus femoris. And the rectus femoris has two insertions proximally: the direct tendon, which inserts in the anterior inferior iliac spine, and then the indirect tendon inserts in the acetabulum rim. It's a very long tendon. It's 2/3 of the length. And remember about rectus femoris when we talk about the acute groin injuries. Now, listening to me, I know that I can talk for England. you say you came here to simplify these things, but you make them more complex, right? Yes, and this was identified many years ago from a fantastic group of people, from Professor Per Holmich, Adam Weir, and their group. 10 years ago, they looked at this, and they looked at the terminology and the definitions of groin pain, and they said, well, we need to simplify things here. They started a study, a Delphi study, and what they did, a very clever thing. So they had a single patient with a single diagnosis, and they sent this pathology or issue to 23 experts from around the world that they work growing. And they asked for the diagnosis. So all these 23 experts, they came back with 22 different diagnoses for one single condition. And what that says, are we saying the same thing in a different way, using different words? And is this makes a difference? Well, if you have a patient who is coming to you, then will come to me for a second opinion, for a third opinion, fifth opinion, can you imagine what that means for a patient who is in pain, who his or her career is in jeopardy at the moment, and they will go, the elite athletes, they will go to 10 different doctors, and they will take, or physiotherapists and therapists will take 10 different diagnoses, what we are causing as clinicians to this person. But it's not only because I say this and because, Per was clever, it's because there is evidence behind it. There are many studies, there are systematic reviews out there saying that words do matter. And they had a review in different terminology on same conditions, and we know that this will influence the management. So following this, we realized that this heterogeneous taxonomy of these groin injuries in athletes will add even more confusion in what it was already a complicated area. So Per and Adam and a big group of people, they created this first World Conference on Groin Pain in Athletes, and they invited these 23 people in Doha 10 years ago, almost 10 years ago, to talk about an agreement. Can we come in an agreement? I'm quite privileged and lucky that I was there in this meeting, and it was massive inspiration for me. And since then, things are so much easier for me. I wasn't one of those clever people. I just attended the meeting and the conference. So what they did, they sat together, it was massive discussions, and they came with what we all know, the Doha Agreement meeting terminology and definitions in groin pain in athletes. And this all, it was a massive momentum occasion. Everything changed since then. And all this is published in BJSM, and it's free to, I can send the links again, free to read. If you're not familiar, please do. So the classification, to make things easier, was what we call it the Doha consensus classification system. And they came up with this idea, how to simplify things. And they defined 4 clinical entities. And this is the adductor-related groin pain, the iliopsoas-related groin pain, the inguinal-related groin pain, and pubic-related groin pain. It's a fantastic picture in a nutshell from Vicky Earle. You can find it online, of course, and have it in your office. It's so easy. Of course, we should never forget the hip-related groin pain injuries, and be careful here, please, because the last few years, I see more and more stress fractures. And these people, hip stress fractures, and these people, they will also present with groin pain. So there are other pathologies, of course, they are hip-related that can cause other causes, red flags always, but also think about 𝐏𝐚𝐫𝐴, think about urology, think about andrology, gastrointestinal, so many other causes out there, and the neural issues that we talked earlier. So what it is, why it's easy for you to then use this system? Because we have a clinical examination-based classification system. So you have the defined clinical entities, and you have a standardized way of, examining. And you will not miss things because you connect all this together. It's another nice picture, you can find it, related to the clinical findings of these entities. So if we talk about iliopsoas related groin pain, most likely we will have tenderness around the iliopsoas. We'll have pain on resisted hip flexion. We will have pain on stretching of the hip flexors. And this is what denotes that the Doha group felt that these tests were more likely, if they're positive, to rule in the pathology. And I'm so sorry that we cannot show people the pictures, but hopefully they will get the idea and then go and look at it. With adductor-related groin pain, we have adductor tenderness. They have pain on the resisted adduction. With ilioinguinal groin pain, we have inguinal canal tenderness. We have pain in the canal. We have no palpable hernia, because then will not be the inguinal related groin pain. It will be hernia, and it's a totally different thing. We will have pain, the resistant testing of the abdominal muscles, and they will have pain with Valsalva, cough, sneeze, increasing the abdominal pressure. And the pubic-related groin pain, they will have pain, local tenderness on the pubic symphysis, and the immediately adjustable bone. We don't have particular tests there, but I think that is quite easy to diagnose. Something else with inguinal-related groin pain, the athletes will have pain close to the pubic tubercle, and also with some very nice picture from Franklin Miller in British Journal of Sports and Exercise Medicine 2009 with pubic clock. It's a really nice picture as well. So the patients, they can point out around the pubic tubercle. And they will say, most of them, it's very interesting, most of them, they will come and it's like they've read the book. The symptoms are worsening with kicking, twisting, sneezing, or by getting in and out of the car. But it's so easy when they present with these symptoms. The surgeons, they looked at it, and we know that the pain for the inguinal related groin pain, it doesn't arise from, it's not a hernia there. Sometimes it will arise from the ligaments, and there are different tendons and ligaments there, like the adductor, the pectineus, the lacunar ligament, inguinal ligament, the conjoint tendon, and the rectus-hip attachment. This is what we call the pubic clock I told you earlier. And again, check if the pain arising from these specific ligaments, and when you request ultrasound, if you cannot perform your ultrasound, put this information down, because the consultant radiologists, if they are not clinicians, they will not know this information. So the Doha classification, I would use it a lot for chronic groin pain. If we talk about acute, so there's the acute onset, which is different. So some little diagnostic tips. There is a lot of work from Andreas Cerner. Andreas is an amazing sports physiotherapist who did his PhD in acute groin injuries in Aspetar in Qatar, and now he's working for FIFA. So only if you put his name, you will find massive amount of information, and you can find a link to his thesis talking about acute injury. So you can find a lot of stuff there. Andreas with Adam Weir and Professor Thorborg and Per Holmich and a few other people from Aspetar looked at groin injuries in Aspetar clinic. So they had a nice clinic there because they work a lot with elite athletes. The people will walk in the clinic after injuries straight away. So they had 110 people working in this clinic with groin-related injuries, and they did a prospective study for the diagnosis of the acute injuries. What they found, what we said already, football is the main sport that we see these injuries. Kicking was 40% the mechanism of the injury. The sports that it is not kicking, change of direction sports are 30+%. 25%, like quarter of them, were negative imaging, and we know this. 2/3 of them, which makes a massive amount, was adductor related. Guess what? From the adductor related, 90% was adductor longus, and this is what I told you in the beginning. Know your adductor longus. 1/3 of them hip flexors, 50% rectus femoris, and iliopsoas.
I read something the other day. I can't remember the paper now, but it said something like, it was a summary that in 90% of groin-related issues, there's likely 3 or more different issues going on. So, for example, it's not just one. Is that something that you've come across? Maybe that's why you get such different diagnoses, because they might be isolating one of them when actually there's 2 other things that have happened.
Exactly. And this is something we always mention. It's not great to say to the patient, I know everything, I'm very experienced. No, we don't know everything, isn't it? And many times I explain exactly this to our patients, that, you can have more than one thing. Like 2 hours ago, I worked with a fantastic physiotherapist, very high level, very experienced with groin, and she texted me, she emailed me to discuss about a patient, and it's like, inguinal-related, adductor-related, it's both. In this case, it's both. And, you can have inguinal-related groin pain and you have adductor-related groin pain, and you can see this clinically and diagnostically. So most of the times, we have more than one entity. And the other thing is that, again, in my last group, I had a patient who had inguinal-related groin pain, definitely 100%. This is how he's presenting. We had the MRI, and the MRI had 𝐾𝐚 morphology, had labrum test, but he wasn't symptomatic for this. It was an incidental finding. So, we treat patients, we don't treat the scans, isn't it? But it's something we see quite often. So 2 things. One, more than one entity can be present there, and that the diagnostic findings are not in harmony with the clinical findings.
I wonder whether the reason there's often 2 or 3 things uncovered. There's a comment here made by Becky who says, I find that when a groin injury comes into clinic, it's usually rather chronic. I assume it's mainly due to the patient being embarrassed about the location of the injury. So maybe that's why they've had something go on. They ignore it, keep playing, something else happens. And eventually, when they can't open their leg or walk properly or run, then that's when we get to see them. Maybe that's something to do with the location, which you mentioned in the beginning.
Becky, you are absolutely right. And I have seen, and I see all the time in my clinic, testicular pain and perianal pain. And, these patients will come to me. And what you do, you have to examine them. You just explain that, there's no embarrassment. This is what we do. And this is the cohort. These are the patients we see all the time. You can relax them. You can break the ice, and then they feel more comfortable, of course. But, remember about all these things, because what you do about this testicular pain, which could be a testicular pain, it's not always groin pain. So yes, they're coming late, but also because the years before we didn't have, now we have more knowledge, we know more. The years before we didn't know that much. And, to me, they're coming quite late. Sometimes they will come for third opinion or fourth opinion, and it is late. But with chronic, even with chronic injuries, with the ductal injuries, let's say, we have very good results with conservative treatment. It's just a bit more different with acute treatment. You have to insist, you have to be, religiously follow this program. You have to wait for good 4 months. And when they live here, we create the program for them. When they live here, we just give this as a challenge and like a homework. We say, we've done what we've done. So now we check your parameters. When you come back, come and prove us wrong. So this is, but we have still with chronic injuries, we still have very good results.
So maybe because we've got a lot of listeners who are sports rehab, they're graduate and they've done degrees in sports therapy. And we've also got sports massage therapists, but often we're the first port of call because when people are in pain, they tend to go to their local sports kind of therapist or something. But maybe because I'm thinking this area is designed, like you said, particularly kind of the adductor complex to deal with fantastic forces. It should in theory be an example of how amazing the body is constructed to transfer these forces from, proximally distally. And yet we're seeing about 5% of sporting injuries related to the groin. So I'm thinking, hold on, why is this area, which is so strong, got quite a high incidence of injuries? And maybe it is because this education where people just think, oh, it'll be all right, just give it a rub. So what are some of the flags where if we are educating our patients, what should we say to them in order to get them in earlier so they're not presenting with 3 different things going on at the same time, which is going to take longer to rehab or even require surgery or something? So how can we get them earlier on?
So I think that what we discuss now, if you keep it in your mind,
okay,
issues, but we say that we see strong patients and all that, their athletes are very strong. What we found over the years, and I was so impressed, people are coming and they say, yeah, I'm very strong. I have this injury here in my groin. And then we check their abdominals and they're so weak. When you ask them, what have you done for your, core and abdominals? But my injury is not there. My injury is in the groin. Why I should? They're also weak. If you have weak abdominal wall, you will have these injuries. And people, they cannot connect it. And this is something again to remember.
And when you're saying weak abdomen, because I imagine, I'm thinking of these guys like hockey players, football players, they're probably doing an incredible amount of crunches. So we're not just talking about the rectus abdominis, we're talking about kind of more of the structures in the abdomen to strengthen. So whereabouts are they weak, do you think? What should they be doing that they're not doing?
We see more runners, but probably when they start their rehabilitation, they focus to the lower body instead of, and control the pelvis. Right. Pelvic control is not great, and you need this for these injuries. So these are two things.
So the traditional lying down doing crunches, which I know a lot of these people will be doing hundreds of, they're probably missing the proper strengthening exercises maybe they should be doing. And yeah.
And,
interesting.
And also they need time. So these people, they're bust, and they want to go fast. It's not you.
Gotcha.
Another good study looked at the acute groin injuries in the adductor muscles with an MRI study in athletes. Again, they found that we had proximal injuries, 26%. From these proximal injuries, again, 75% is complete rupture. And I want to say this because we have really, really many ruptures, complete ruptures, and people, they don't think about this. We do have 30% intramuscular proximal tendon and then 37 in the distal tendon. What else is important? Right. I discussed earlier about standardized clinical examination. And in my early years, I was like, I have the knowledge, I examine, this is the test for this pathology. No. the last 10 years, what I do, 10, 15 years, I have standardized clinical examination. And we share this template with the whole team. So I don't have to examine. Physiotherapists will examine, sports therapists will examine, and I just look at their eyes and I know what they're doing. And the other way around, I can examine and they understand, because we have this standardized clinical examination, and we know again from evidence that such examination can predict the presence of groin injuries better, and the location better of an MRI. Will do. Not for everything, but we know from again another study, I think was 𝐷𝐸𝐻𝐸𝐻 again study, and Adam and Per Holmich. So they found out for the adductors, you can. The clinical examination can identify the injuries, and this has positive predictive value, 93 to 97%. And the other way around, the lack of pain on the palpation can rule them out, and this has negative predictive value, 91, 96%. So if the patient will come, the athlete will come and say, I had this massive injury and this and that, and then you examine them, there's no pain there, there's negative predictive value. So, it's very important, and it's a very good study as well, and, you don't need an MRI. Epidemiology-wise, if we see why we say know your adductors, there are studies from Werner with comparison 2019, 2018. He looked at the groin injuries, and then it was 64% with 10 years different for adductor-related groin pain, about 10% iliopsoas-related groin pain, 4% inguinal-related groin pain, and 5% hip-related groin pain. And this is stable, like 10 years difference in BDSM is published as well, the same. Then Professor Holmich did another study in 2013, and again, high adductor-related groin pain, 30% iliopsoas, 90% inguinal-related. And more recently, again, 𝐷𝐸𝐻𝐸𝐻 published something in the American Journal of Sports Medicine for the clinical diagnosis of acute injuries. And again, 66% adductor-related groin pain, 25% iliopsoas-related groin pain, 10% rectus femoris, 20 plus abdominal, and then 6% sartorius. So that's why I just insist about your adductors. And I think it's really important to know that. In terms of treatment, Ben will talk about treatment next week. But for the acute groin pain, for the adductors, I use a fantastic protocol. So honestly, you can go and download it from Aspetar. They have a fantastic protocol. Then you can look at it. So I don't have to go through the phases. It's all 4 phases, one by one, step 2. Go and look at it. It's great. And for the chronic adductor-related groin pain, I will use the Professor Holmich protocol again. And this was, it's interesting, right? But he's one of the experts of the experts in the world, and I'm really, really grateful and privileged and honored to work with him and with Per and Christian Thorburg and all this, this group of people. So Per, back in 1999, published in Lancet the multimodal treatment, Holmich protocol, and this is what I use. And to be honest, 25 years down the line, it does work. It still works. It works very well. There's a secret there. So for this protocol, there's some important elements, and the important elements is many repetitions. We want at least 8 to 12 weeks, I would say, 3 times weekly, at least 90 minutes duration. Exacerbation of the pain and all that we know. And Per says that if there's no pain, they can return to run in 3 weeks. Now, we see good results in 4 months, and that's why I say to my patients, follow religiously this protocol if you want to get better. And they're getting better. And this is fantastic. Then with the doctors, and I will let Ben to talk about it next week. But Ben will talk about obviously the conservative treatment, which I am the biggest fan. It doesn't matter that I'm surgeon. I'm born to be surgeon. I trained 1,000 years to be a surgeon. I love operating, but you need to have evidence for everything you're doing. And what other treatments? Let us talk about surgical treatments because I'm the person to talk about it. Shall I go for a ductal tenotomy? It does work. When we'll pass the baton to the knife. When everything else fails, and also people that will come to you and say, "Oh, I've done everything." Okay, what do you have done? Most of the people, they will say, I've done a lot of physiotherapy. When you see their program, it's not what they should do. So you start from scratch. So a ductal tenotomy, it does work, and there is evidence out there. And again, there was a publication in Lancet, again, from Per 𝐿𝐻𝐚𝐫𝐿. He looked at level 4 studies, and he had really good results, like 54 to 75%, excellent results. Poor results, only 8 to 15, I think. And just a very little complications, 5 to 30 maybe. But he had the other group, the active exercise program group. And the results there were excellent, 80%, really, massive number. Poor 3, and obviously there's no complication with it. You cannot have complications, isn't it? And then what he did, he looked at this many, many years later, and I think 12 years later, what happened with this ductal tenotomies and with this follow-up, and he found out there was significantly better results with the active exercise group, much better with soccer players, and what that says, that exercise works.
Mm-hmm. Could you explain the procedure you're talking about to give the listeners an idea of the surgical procedure? What is it you're doing with this?
It's just a simple tenotomy. It's not a complicated.
It would be for us. Would be for me. Believe me, I can hardly cut chicken without it falling off the plate. So yeah, what do you do? What is it? What's involved?
We go through procedures at the end, because I have few more procedures to talk.
Okay. Yeah.
With everything, and then we'll go through the.
Okay.
Yeah. Mm-hmm. Now, 𝐸 related, and now something it's interesting for you, because a lot of times you will ask me, or you will send patients for injections. I know all my ERIs, all the therapists, they will, can we inject 𝐸. And I'm like, I hate injections, but when I have to inject, I will inject, of course. But for 𝐸, I don't like the injections. The only reason I would throw steroid there, it's only for rehab purposes. So if the people will find it difficult to follow the strengthening exercise program, and they're so symptomatic, and then we cannot rehabilitate them, it's the only reason to inject, right? And of course, always ultrasound guided related injections, not blindly. It doesn't matter how much experience you have. this to be done from particular people that they have experience, and it's not a bad thing to say I don't have the experience or I'm not good. If you ask me about shoulder today, I'm the worst person to talk to you about shoulder. So I'm not good. I will send you to someone else to talk about this. Tenotomy, you don't touch the iliopsoas, don't cut them. I know that many orthopedic surgeons will operate on iliopsoas, but this is a surgical procedures we do after sometimes hip replacement and for other reasons. So iliopsoas, we don't inject. If we inject, we will inject only for rehabilitation purposes, because for these people to continue the strengthening work. Why? Because we know that strengthening the hip flexors will give you about 7% of strength improvement in 6 months. Of course, it's not something I'm saying. This is another fantastic study, like 5 years ago, I think, from Christian Thorborg et al. So why you operate? Inguinal related groin pain now. Again, we talk about abdominals, strengthening the abdominals, strengthening all the muscles and work on balance and coordination around the pelvis. But again, Ben will talk about this next week. When we operate, you have heard terminology like groin disruption and stuff like this. There are some procedures when we talk about surgical procedures. So several, there are many. But again, when every conservative treatment fails to improve, then you go. These procedures are mainly tensioning and detensioning. So one of the procedures is the eponymous procedure from Professor 𝐿𝐲𝐬𝐻, and it calls 𝐿𝐲𝐬𝐻's inguinal ligament release. So what Professor, now we talk about procedures, what Professor 𝐿𝐲𝐬𝐻 likes to do, he operates on football players mainly. With the scope, he will access the inguinal and the lacunar ligament, and he will go to look at tears and inflammation. Then he will go to the pectineal ligament and then will release this ligament if this is under tension. So this is the detensioning technique. So he says that the tension in these ligaments can cause this pain and the inflammation and the tears around these very, very, very tiny ligaments, but play a massive role, looks like.
So what does that mean when a surgeon's releasing? Because a lot of soft tissue therapists use the word release as in like relax the nervous system down. But what are you saying? How does a surgeon release a ligament?
You detension, you cut the ligament, you just release it surgically.
Oh, really?
I'm not a massive fan of this procedure.
But doesn't that ligament need to be kind of, forgive my ignorance, but doesn't cutting a ligament kind of defeat its function?
Everything is there. Should stay there, isn't it?
Yeah.
So then he will apply a mesh, and then what he does, the athletes, they can stretch in 24 hours, and they can go in 1 week to play. And this thing, as you know, a football player, elite football player, they have the pressure to go back, and this is one of very famous procedure in the past. I don't have many patients that they had this procedure, but those people, they had it, had good outcomes. If you ask me if I am fan, I cannot tell, because we know that anecdotally we have good results, but there is not massive published evidence, and we need this published evidence. On the other hand, we had another fantastic procedure when we are struggling with people who think that inguinal disruption there. I work very close with Professor 𝐿𝐸𝐻𝐿𝐻. Professor 𝐿𝐸𝐻𝐿𝐻 is in Manchester, and he worked many years around groin and inguinal related surgeries. So this is a very specific procedure as well. It's the MGR, the Manchester Groin Repair. It's a modification of TEP repair. So, but essentially, what is the difference? He will use a larger mesh, about 12 centimeters, and he will place this mesh with automatic fixations. And what he does is he will ensure that this mesh will cover at least 3 centimeters below the Cooper's ligament. Plays big role. I cannot tell you why, but all the patients I had from Professor 𝐮, they had amazing outcomes, really good outcomes. The secret for this is they come first to us. We strengthen, we give them the strengthens. They have this, what we call it, prehab. They will have their rehabilitation. 4 months later, they will come, and then we would feel that maybe, we cannot improve them more, and we'll start the prehab. So they're going really strong to have the procedure, and once they have the procedure, they will start early rehab, and then they will come back to us to have advanced rehabilitation, and then they're going back home for 3 months. And so far, I have seen amazing outcomes.
So this procedure is a mesh, yeah? They put a mesh underneath.
Yeah, in both procedures, okay. Most of the people, they will put mesh because you have to support a traumatic mesh, because you have to support this abdominal wall. These people are athletes, so you have to support somehow.
So the mesh is an artificial way of providing extra support.
Yeah.
And that stays there.
And then stays there. You don't like it. And the reason I'm saying this is that this can cause problems. So if we find out in the future some of them, nerve complication is one of the complications we don't want to see, because then you cannot do much. Of course, you can remove the mesh, but it's not a good idea. So we try not to, and then we start working with neuropathic medication. It's not a great complication for someone to have. But Professor 𝐿𝐸𝐻𝐿𝐻 is doing this for many years, and he has massive amount of publication on this. So the evidence is there, and also himself, he is one of the people that they are fan of the conservative treatment as well, and he will not jump because as surgeons, what we know to do is operate. So we will jump to operate. The new generation of surgeons, they don't do this, but also they have extra knowledge, and thanks God, all the work we're doing, it's an interdisciplinary work. So at the moment, and then I'll come back after summer, we are working with the European Society of Sports Traumatology and Arthroscopy. I'm again privileged and really honored to work with this with another 15 experts, groin experts from around the world, and we're working on a groin consensus. Right now, we're working now about 8 months, but still a long way to go. So we'll bring you new evidence. What I want to say, we know more in this group, and in every group I work for consensuses and Delphi studies and studies. We have exercise instructors, we have physiotherapists, we have radiologists, we have surgeons, we have sports and exercise medicine consultants, and it's eye opener. It's eye opener for the non-clinicians, for the radiologists, for example, the other way around. So we know more nowadays. So we don't jump straight into conclusions. We don't jump straight into surgical procedures. In another surgical procedure, again, not to forget, because not many people know about this, when we have plaque injuries, the injury we mentioned before, we know that pyramidalis muscle plays important role in adductor injuries. The 6 types of injuries depend on the injury. You can work hard again with conservative treatment and rehabilitation, but it's, if you cannot achieve what you want, then it's the surgical procedure. And for this procedure, of course, I suggest people to get opinion from Professor 𝐼𝐻𝐿𝐻, who is the person who, discovered this complex, and he's the guru. He knows a lot about these injuries and how to operate. He's an orthopedic surgeon, very well known international.
Fantastic. It'll be interesting next week when we talk to Benoy Mathew about treatments, and we've had a magnificent overview of when surgical procedure can help with rehab, but it'll be interesting to hear what we can do to stop it from getting to the stage where surgery is needed. A lot of the examples you've used are surgery in the mesh. It was mesh, by the way, Penny. Mesh is the word. Yeah. Is it often like an elite athlete, like somebody who's got to return to playing, who have these procedures done, or are these done also on general public and people who are...
Not only, but with these people, because they want to come back to play, but the general population, obviously, because nowadays we all training, isn't it? It's not like what it was 20 years ago. Everyone is an athlete.
And well, it should be, yeah.
This is a problem sometimes, because if you're in your 40s and you've been an athlete in young age, and you then go to play football only the weekend, this is when you kick the ball, you will receive this, you will have this kind of injury, adductor related or inguinal related injury.
I'm interested as well, because sometimes groin injuries, particularly as athletes, are badly educated, and that's a lot of the work you're doing in trying to simplify it and standardize it, which is amazing. But sometimes, maybe because they're putting up with it and not getting attended to, you can reach life-threatening situations with certain complications. Have you come across any of them, like bone infections or strangulation or stuff, intestinal strangulations that happen quite often?
Absolutely. Absolutely. I mean, first of all, if you have inguinal related groin pain and something around the testicular area or something like this, it's different. If you have the experience, you can see it, and you can find out it's a different presentation. But always, if there is a little suspicion there, I will ask first for urological opinion, because this is a case where things can go wrong. With the musculoskeletal point of view, what can go wrong? So yes, we do, and with bone as well, you have to be very suspicious. We see a lot of stress bone injuries and fractures, so you have to be careful there as well. And of course, as I said, sometimes it's different. 𝐏𝐚𝐫𝐿, the ladies had a lady who presented with a massive cyst in her ovaries, and it was like a growing pain. But you don't know what is the cyst, isn't it? So the cyst can cause serious problem, but it's a little.
So it's one of those important case histories, and I'm sure we'll talk about it next week as well with Benoy. But if there's like nausea or vomiting or anything like this, like a systemic sign that something's going on, this is where, because a lot of our listeners will be in that perfect place where they're the first point of call, that it's outside of their scope. If they ask the right questions, they go, "You say you're being sick? That doesn't sound right to me. You need to go and see so and so." Then you could save these people a lot of.
Absolutely.
Yeah.
Because we know that can be, as I said, 𝐏𝐚𝐫𝐿. It can be andrological, urological, gastrointestinal as well.
Right, fantastic. Well, look, that was a quick hour. That zoomed by. But yeah, amazing look at the, once again, rather like Dr. Rollins last week, you've given us such a good look at the anatomy and also when surgery is needed. So it'll be really, like you said, it'll be a really nice flow next week when we talk to Benoy about what we can do for conservative measurements. Fantastic, really cool. Yeah, time has beaten us, so we're going to, I think earlier on, Penny, I could hear your frustration or fear of, are we going to get all these links? I will make sure that if you send me everything, we'll make sure they all go into the show notes.
Absolutely, and I could send you. I mean, 2 years ago we had a fantastic conference attended by 6,000 plus people with the British Association of Sports and Exercise Medicine, amazing. Professor Holney and Adam Weir and me. And I have the links of the entire conference dedicated to groin. I'm very happy to share this with you.
So we're going to have some big show notes. Penny said, I would love to have a template of that standardized clinical examination. This was going back to the adductor, wasn't it? Where should we go for good ones, I wonder? Well, Penny, don't worry. We will have a long list.
Make an effort. I will send you.
Thank you so much. And as we said at the beginning, it's very much worth following Dr. Dora Papadopoulou on social media, which is at Dora_SportMed. That's DORA_SportMed, because you do manage to somehow, thankfully, put out some wonderful information as well of all the different types of work. We haven't touched on a lot of the other, not plates you're spinning because you're in total control, but a lot of the other pies you've got fingers in, and to do with like diversity and all sorts of wonderful things going on. I don't know how you find the time, but
we try to bring more people from diverse backgrounds and women in the British Hip Society are doing fantastic work with these groups, and please bring women and people from diversity in a bit from different backgrounds, and we're here to support. Women are fantastic surgeons. Please be one of them.
But having people like yourself and Dr. Sarah Rollins last week, I mean, it's amazing for us. We get fantastic feedback from our listeners just going, it's so nice to see, you know, examples of women, whether they're surgeons or anything, sports rehabilitators or something. But yeah, it's great. You guys really set a wonderful, you're inspirational for our listeners as well. So thank you for that as well, the job that you're doing. Right, people, I know it's now 9:03, so I'm going to say thank you. Penny, I think, has summed up what all of us are thinking. This needs a couple of more listens, Matt. Yeah, we definitely do. There's a lot of information there. I just let Dr. Dora Papadopoulou speak for the first 25 minutes because there was so much going on there. But so I agree with you, Penny. I'm going to listen to it back. I'm looking forward to it myself. Penny says, thank you, Dora, for sharing all your knowledge with us. Westbrook Wellness has also said, great to listen to you, Dora. All the best with your research. Maybe see you at Sparta again soon. What? Is this somebody who's done Spartathlon then? Who is this? Westbrook Wellness?
So, I'm the doctor for the British Spartathlon team, and I do the Spartathlon for about 15 years. It's just a simple race of 148 kilometers.
A simple race, 153 miles.
27 hours running, so many injuries there. And it's a fantastic place to be ultramarathons.
What always makes me laugh about that, and I'm not sure if it's a myth, but obviously it's based on the run of Phidippides, is it? Running from Athens to Sparta, and on the Battle of Marathon to announce it and send the news. But what they don't seem to mention in that beautiful story is that shortly after managing this 2.5 or day and a half run, he died, didn't he? He collapsed and died. Yeah, but they forget about that bit. They put a race in his memory, but they forget the fact that the original guy who did it.
But now we do this, and it's not commercial. It's very historical race.
Oh, beautiful. Yeah.
Sparta's team is probably the best team ever, from 500 people, and I don't know how many countries, 150 countries, the British Sparta's team.
So you say you've been involved in it, or the doctor for like 15 years? And you're regularly there, are you?
Yeah, just last year, it was only 2 years I wasn't, and this was because at the same time I was involved with the International Federation of Sports Medicine. I was in those committees. I was delivering lectures. Last year I was in Mexico. The year before I was in another conference, and
Oh well, no, you can't be. Even you can't be everywhere at the same time.
But I'm there. This September. the first week.
Yeah,
last week.
fantastic. No, I'd love to go over there. I think we were talking off air. I'd love to go. I'm a big fan of Paphos. I'd love to go and do the marathon there, but it's in March sometime when there's no holidays. I've got 2 kids, but I love running in the heat, and that'd be beautiful down as well. Yes, Penny, he did die. I'm sure I have to look it up. I'm not sure if it's just a joke, but I'm pretty sure that Pheidippides did collapse and die after this magnificent 1.5-day run to 𝐶𝐴TE against the Persians. But anyway, let's not bring it down. We'll keep it all happy here. So wonderful. Once again, then. So thank you, Dr. Dora Papadopoulou, for joining us. Very kind of you giving up your time, given that you're so busy. I think I'm sensing we're going to have to do a part 2 at some point, because there's so much information. There's so much which I'm sure you would have loved to have shared as well. So we'll hopefully do that. But in the meantime, for people who are listening, you can follow Dora on Twitter. Next week on Dora_SportMed. Next week we continue. It will be very much a follow-up to this, with Benoy Mathew of Function2Fitness talking about treatment for groin injuries. And then the last week of this focus on abdomen and groin, we are going to have Jenny Bowell of Bowell Education really diving deep into diastasis recti, which Sarah had a look at last week, but that is Jenny's passion, and we're going to be looking at that, which will be a great episode as well. So it's going to be an incredible month. So thank you very much. If you listen to the podcast and you feel that you'd like to actually join the live episode and have a chance to ask our guests questions directly and hang out with other like-minded soft tissue therapists in the live lounge, then all you need to do is go to the Sports Therapy Association YouTube channel. Like I say, next week with Benoy, it'll be a Wednesday. The week after, it'll be a Tuesday. But yeah, if you're free at 8 o'clock GMT +1 is where we are at the moment. Then come along and join us. And if not, if you prefer the podcast, that's great. But do please leave us a review and a rating so that the good word of our guests gets out there further. So once again, thank you, Dr. Dora Papadopoulou. Thank you everyone for joining us. And hopefully we will see some of you live next week. Take care of each other.